So good evening everyone, and I'm Dr. Neelaveni from Usmania Medical College. This is a ICMR funded project. So where we are working on the early detection of peripheral neuropathy in the peripheral health system. Care model for foot health in diabetes and leprosy. So we have collaborated with the leprosy. Lepra is an NGO which is working for the leprosy. So the common problem for both leprosy and diabetes is the neuropathy. So and I am working in the tertiary care center. So I am the principal investigator, and from lepra also we have the co-investigators. No, I am an endocrinologist. So basically, we are a collaborating partners, madam, because they have a foot care unit to prepare the footwear. So peripheral neuropathy is the most common microvascular complications of diabetes and an important risk factor for foot ulceration, and prevalence ranges from almost 66%. So guidelines recommend annual peripheral neuropathy assessments, which is the standard of the care, with more frequent monitoring for high risk individuals. So, but what is the gap? So limited technical knowledge and inconsistent practices among healthcare providers, especially in the peripheral health system. So the proposed study is enhanced to enhance the technical capacity of the peripheral healthcare providers. So through structured training and the sensitization, establish a referral system linking the primary, secondary and the tertiary levels for timely diagnosis and the management. We are trying to educate the peripheral health workers, including the medical officers at the PHC, staff nurses, ASHAs and the ANMs across the level. So we have a 3 objective, so which is ongoing. Now we are in the second year of our project. So first we have done the situational analysis to understand the existing practices, what is their knowledge, what is the limitation of doing this, so which is a cross-sectional. So we have chosen a Medchal district which is nearby Hyderabad, so which is almost 50 kilometers from the our institute. So key methods, 236 in-depth interviews, which is a qualitative analysis with health staff and officials, mapping the existing interventions and gap identification so that we can develop a protocol for the training. Now we are in the second phase of our study, so capacity building. So we are near completion of our second objective, to upskill the primary and secondary health workers on the peripheral neuropathy detection and the management. So which is a quasi-experimental study. Almost 900 health workers have been trained so far. So training on the 10-gram monofilament testing and the vibration perception using the tuning fork and the simple clinical palpation of the pedal pulses. So and the referral pathway. So we are training them. So training the ASHAs to look into the feet of the patient whenever they go to the visits, field visits. Any abnormality, you ask them to refer to the PHC. PHC medical officer will be trained in such a way to just triage, simple triage, look at the active disease, immediate referral to the tertiary care. Any problem where callus is there, callosity is there, or corn is there, refer to the secondary level where it can be removed and properly advised. So this we wanted to establish. So now third will be we have not gone into the third stage. So that is implementation. After training, we are utilizing their services to screen their PHC patients, like diabetic patients attending the peripheral health system, so that we will be cross-checking whether they have done and maintaining the register. Already in the PHCs there is a NCD register. So whatever we have trained, whether they are able to enter, they are able to identify correctly, we will be cross-checking. And we will recruit them also for the prevention as well as the treatment of the ulcer. So this is the situational analysis, like themes, diagnostic practices. So from the medical officers and the staff nurses, so there is a knowledge gap was there, and protocol, they were not very much aware, and there is even tools were not available in the peripheral health system, this we all know, and even regarding the treatment and the medication practices also there was a limitation. So provision of only anti-diabetic medication, even sometimes they never used to, actually they never looked in at their feet also, and system related, the staff crunch, all those things, and follow up and monitoring was a difficult. difficult. So in patient adherence also, sometimes even if they identified they refer, patient will not be able to go to that far for the tertiary care levels. These are all the gaps identified in the system from the medical officers. Even the ASHAs also, there was a knowledge gap, limited knowledge. Some people were not aware only food problems in the diabetic. And so there was again time constraint was there. Again there was a barrier with respect to the patients also. So even patient perspective also, there was a poor knowledge. So many of the people were not aware on the self food care education, and even though somebody has advised to go, so for there, because they will be working for the daily wages, they will not be able to go. So these are all the gaps which were identified. So coming to the objective 2, which is the capacity building. So we have prepared, which are validated training modules for the medical officers and the staff nurses separately, and for the ASHAs. So like we have trained them with a hands-on training, monofilament, vibration, and the pedal pulse assessment. And we also have prepared some charts, how to risk identify, high risk, refer to the tertiary care. So, and the basic food care and the referral and the implementation and reporting. So for the ASHAs also, just basic food care education, what you have to tell to a diabetic patient, self food care, how it has to be taken with the charts we have prepared. And look at the problem, look at the foot and ask them to examine their feet regularly, and whenever there is a problem, refer to the PHCs. So these are all the simple tools we have provided, which can be pasted, because PHC patients, they will have a booklet. So we told them to, and this is the food care education posters we have prepared, we have kept in the PHCs. And the risk stratification also, which is color coded to make their job easy for the medical officers and the staff nurses, was kept in the PHC centers. So these are all the again different for the ASHAs reporting also, because we have to check whatever we have trained, whether they are utilizing these to educate them. So we have prepared a reporting so that we ensure, or we will be going to the fields and cross-checking also. So progress made so far with respect to the objective 2, so 20 batches of trainings were done with a total of 900 healthcare personnel, 796 ASHAs and 104 medical officers, staff nurses, and 44 specialists like in the secondary care centers. So 9 primary health centers and 44 UPHCs, 25 Basti Davakhanas, and 1 training of the trainers. We are training, like we have selected few enthusiastic, dynamic medical officers, so to utilize them for continuation of the training. So I think this is ongoing, and we hope it will be done, and this is like a model thing we have done. So if this goes well, everything goes well, probably we would like to implement across the peripheral health systems.